Now I would like to call upon our next speaker, Dr. Kishore Pichamuthu, who is the Professor and Head of Medical ICU, CMC Vellore. Sir is trained in ICU sonology in Westmead Hospital, Sydney, Australia, and he has held several workshops and has a keen interest in ICU sonology, including he has been training all of us in our department. So we welcome you to this session. I hand over the stage to you for your presentation.
I'm Kishore Pichamuthu from Medical ICU here in CMC. And like was mentioned, my area of interest is ICU sonology. And so I'll be just talking about how I would optimize fluid status in a dialysis patient. Now, just we just look at the role of point-of-care ultrasound, generally in medicine and particularly in nephrology as well. And then we will go on to look at how we can do a volume status assessment using POCUS, using IVC as well as cardiac ultrasound. We'll look briefly at detecting venous congestion systemically using VEXUS, and then go on to look at lung ultrasound to detect how wet the lungs are. And then we'll put it all together to see how we can use this to manage our patients. So point-of-care ultrasound has been evolving for the last 3 decades or so. And it is ultrasound that's performed at the bedside by clinicians. It is developed most in emergency departments and ICUs, but then it is now spilling over to other branches of medicine as well. And some of the reason is that, of course, there was a need for newer, more specialized uses of ultrasound. But it's also that the peripheralization of ultrasound has been made possible, also because I think radiologists have kind of slightly given up their turf at some point and allowed us to also do it. In the early days, there was no way we could actually practice ultrasound outside of the radiology department. And that has changed. And I think definitely that has helped ultrasound develop so much in each specialization. And definitely that's here to stay and to go on. Another very critical component of this development of point-of-care ultrasound is actually the development of small portable machines, and which are light, portable. They're really small. They're all battery-powered. They boot up really quickly as compared to the ones in the radiology department, and you can store it. You can do a scan quickly and look at it later. And of course, they're very rugged because you're actually moving it around, using it. And so all of this has helped. We've started this, 20 years ago, this is what we started off with. And now, with technology becoming, things have become much smaller. We have these ultra portables, really handheld devices. So this is the Clarius and the Philips Lumify, and there are so many other brands. So all of this has made it easy for everyone, every clinician at the bedside to use ultrasound. Okay, so that's the equipment part of it. Of course, there were other situations that kind of helped accelerate the development of point-of-care ultrasound, and one of that was the COVID pandemic, when many of the traditional diagnostics we couldn't do, and you had to depend a lot on point-of-care ultrasound, and especially lung ultrasound really took a leap forward during the COVID pandemic. And that kind of triggered some other things like legalization of ultra-portables. It was not possible to register very small devices in our country, for example, prior to that, and now you can. So all of this has kind of helped. And of course, we now know that anyone can be trained to do ultrasound, and it is not for the radiologist or the cardiologist. And so this training also is not very extensive like it was taught earlier. So point-of-care ultrasound, being very focused ultrasound, can be taught within a few hours if it's only for a specific skill set. So you can teach within a few hours, and then you can supervise the first few scans, and then the person is good to go, something that you can't really do in traditional ultrasound. So, and many studies have shown that even such short training programs have led to as good pickup rates as more experienced sonographers. But unfortunately, there is no good way of certifying and assessing competence and certifying somebody as of now. And this is not just in nephrology, even in ED and in ICU, we have the same problem. There have been some societies that come up with their own certification, but nothing really of that's really perfect. There are other issues. If you're doing all of this ultrasound that we'll be discussing, how do you report it? Can you report it? Can you charge for it as a separate test? Is it legal to do that? And so that may not be really possible, and that could actually cause some kind of a legal issue. So often what we do is, because for this point of care ultrasound is really an extension of our examination and our assessment. And so we would treat the ultrasound just like we would treat the stethoscope, an expensive one. So we would use it, we document the findings just like we would document examination findings, maybe in the same place often, and not as a separate report. And how is it billed? At least in the ICU, we've gotten around this problem by not billing it as a separate investigation. It's part of the equipment, so the general monitoring cost is raised up to cover the cost of the ultrasound machine, because we would use ultrasound on everybody every day anyways. And so that's how we've got around it. Anyways, so point of care ultrasound can be used both diagnostic or therapeutic. And very important to understand that POCUS is very focused, and it answers specific clinical questions. It's not meant to replace a comprehensive study. Very often our point of care ultrasound, we may find something and then say, okay, let's call the radiologist to kind of have a look at the whole thing, or call the cardiologist to have, give us a more comprehensive report. But we've answered the clinical question that we had, for which we did the ultrasound. So that's very important to understand. And in nephrology, there are a number of clinical questions that can be answered by POCUS. You already are extensively for many, many decades been using ultrasound for vascular access. And you could use it to even diagnose problems with access, both intravascular access as well as AV fistulas. And you've also probably been using it to look at the bladder and the kidney for various pathology. And that use has now expanded a little bit to go on to look at vascular volume, to look at the lung for various pathologies, including how wet the lung is, to look at the heart. A lot of your patients are also going to be having concomitant cardiac pathology, which influences your treatment decisions at that point in time, and so you can pick that up. You can look for raised ICP when that's relevant. You can look for infections, sources of infections, which are common in your patients as well. So it's just expanded from its initial use that you are probably used to. So usually when we think of point of care ultrasound that I want to use in a patient with dialysis, the first thing that comes to mind is, can I use it to look at volume status to find out if a patient is truly hypervolemic, and if he is, how much, so that if I'm going to dialyze him, could I decide how much fluid I need to take out in this patient? Now, of course, we've been using clinical examination all this while. Why not just continue with that? There are two things, of course. Clinical skills are waning, and I think we all agree on that. But more importantly, even good clinicians have a very low sensitivity to detect actually increased intravascular volume. That's because many of the signs that we use to say that a patient is overloaded, they are not sensitive, and some of them can also be caused by other pathologies. And so it's not very accurate. And in heart failure, we have sensitivities documented between 30 and 40. And in dialysis patients who may not be overtly overloaded, just they've come for maintenance dialysis, you're just trying to assess how much overload, how much of fluid excess do they have, then the clinical signs are hardly sensitive at all. Okay, compared to ultrasound, they fare very poorly. And so we can't really rely on clinical signs. And this is a problem I face in the ICU when many of these signs can be produced by the other pathologies that the patient has. A patient already has a lung pathology. He already has a hemodynamic instability, making it very difficult to assess this. And so we really face this problem of the poor performance of clinical signs. Before we actually go on to looking at the ultrasound images and how we can interpret it, there are a few conceptual things that we need to just make sure that we understand what these terms mean. One is volume status versus volume responsiveness. There are different ultrasound findings actually reflect these two different things. Now, volume status, when we talk about it, is what we refer to when we say someone is hypovolemic or overloaded. We're talking about increase in the intravascular volume. Okay, so that's volume status, and that's what we want to find out. But sometimes when someone is in shock, for example, there's a slightly different question. When I want to assess his volume, I'm not just looking for is he volume depleted or overloaded. Irrespective of where on that spectrum the patient is, I'm trying to find out whether he will respond to additional fluid. And so that is volume responsiveness. So you'll see as we go along that some of the things that we see on ultrasound reflect one and some the other, okay? The other is signs of increased pressure versus increased volume. Now, when we look at some aspects, now even clinically, if I'm looking at the JVP and saying, okay, the JVP is elevated, that kind of suggests that he's probably overloaded. Actually, the JVP is only reflecting pressure from the right heart. But then we are saying, okay, most often that is because there's a fluid overload. So we must understand that sometimes some of these signs are because of an increased pressure. So it's possible that the volume may not be increased, but there may be an increase in pressure. We'll see some of those situations. And of course, there may be, for example, there's a difference between volume increase and volume redistribution. The weight of the patient may not have gone up, and yet he has come in presenting with wet lungs. And that would suggest that it's more of a volume redistribution than an increase in volume. And of course, the ultrasound is very good at differentiating these two as well. And importantly, often when we think of the volume, what comes to mind is the IVC and or the SVC or IVC or the IJV. So, but we must remember that it's a composite, that we must look at the IVC, the cardiac, look at systemic venous congestion, and the lung together when we interpret. And we'll look at each of these individually, and then we'll look at them together. So let's look at the IVC first. So how do I look at the IVC? I can use a cardiac probe or an abdomen probe. That's a curvilinear probe. This is usually a 2 to 5 megahertz probe. And we place it just below the xiphoid, slightly to the right, maybe a centimeter to the right of the midline with the dot marker facing headward. So I'm trying to achieve a longitudinal view of the hepatic IVC. That's what I'm trying to do. And what we are actually using is we are using the liver as a window to look at the IVC, and we are going to get a longitudinal view of the IVC. Now, what we are actually seeing here, this is the dot marker, so that's the cranial part of the image. And so that moving structure there is the right atrium. And we see the IVC is entering the right atrium. You can see it clearly entering. And not so clear in this particular view, perhaps that's a hepatic vein. The hepatic vein usually enters the IVC just before it gets into the right atrium. And this, of course, is the liver. So this is the view that we're trying to look at. Now, there are, of course, some quality markers that you have to ensure before you start interpreting. Okay? So first is to make sure that you're looking at the IVC. Why is that important? Because there's another tubular structure to the left of it, which is the aorta. And it's possible to look at that and think that you're looking at the IVC. In a very hypovolemic patient, sometimes the IVC will be absolutely flat. You can't see any volume inside it at all, no anechoic space. And so as you're scanning to look for a tubular structure, you'll see the aorta. And so you'll think, he's well filled. And so that mistake we shouldn't do. So the IVC enters the heart directly into the right atrium. You can see it entering. The aorta, on the other hand, seems to be going tangentially behind. And you can actually see the hepatic vein entering the IVC. And of course, you would see no such vessel on the aorta. And very often, I always suggest that you scan and sweep the beam to the left so that you can visualize the aorta and say, okay, well, that's the aorta, so what I'm seeing is definitely the IVC. Now, the IVC itself, you should make sure that the walls of the IVC are white and distinct, okay? Very clear, sharp lines, not fuzzy lines. That way, you're sure that the ultrasound beam is going right through the middle of the IVC. That's very crucial, because one of the signs that we're trying to look for is an IVC that's collapsing. That would suggest hypovolemia. And if you were to go to the edge of the IVC and not be in the center, you'll see that the walls seem to be touching each other, and that's not a real collapse. It's a pseudo-collapse. So you need to make sure that the walls are distinct, and you should get a long section of the IVC. So that's another way to make sure that you're in the middle of the IVC. So once you've done that, one is to look at it qualitatively. Just look at it and see how it looks. This, for example, I mean, all of you would agree. I mean, this is a small, it's collapsing. As it is, the diameter of the IVC is really small. And you can see that with each breath. This is not with compression, remember. This is just with breath, respiratory variation. You can see that the IVC walls are touching each other, so the IVC is collapsing. So this is a small and collapsing IVC. On the other hand, the previous video that you saw, you can see that the IVC here is quite plethoric, it's quite fat. It's not a flat IVC, it's a fat IVC. And it's not varying with the respiration, okay? So no variation at all. So that suggests that the pressure inside the IVC is fairly high. And of course, you could have combinations of this. This IVC looks fairly fat, but you can see that there is some degree of partial collapse on inspiration. So it could be a combination of all of these. Now, this was just qualitatively looking at it, but you could also make measurements. And often to make measurements, we use an M mode, but you can make it on 2D images as well. So the first, of course, is to look at the diameter itself and see how fat the IVC is. Now, there is very difficult to standardize it because some of the Western numbers may not apply to our IVCs. But generally, if you see an IVC that's more than 2 centimeters, okay, that's large. If it's less than a centimeter, maybe that's a bit on the smaller side. Okay. Now, we must remember that you know, in a normal individual, if you just took a normal population and looked at some of us, for example, just sitting here, many of our IVCs would be on the small side, maybe even collapsing. That doesn't mean anything. Okay. So if you were to just incidentally find it, don't read too much into it. Okay. So that is important to remember. So the large variation, and if someone is in shock or you're making an assessment for hypervolemia, then of course it would make sense to actually measure it. We also know that, so if it is on the hand completely collapsed in someone who is shocked, for example, then that's significant. Okay. In a patient with shock, where I'm not looking for just volume status, I'm trying to look at, should I give this patient more fluid? I'm trying to look at, okay, first when I look at it and it's collapsed, I know he's obviously, he's hypovolemic, I can go ahead and give him fluid. But if it looks normal or fat IVC, it doesn't mean the opposite. So a small or a flat IVC generally tends to reflect hypovolemia, whereas a normal or a fat IVC doesn't mean hypervolemia. Okay? So by itself, actually we don't give it any meaning at all. If it is fat and you find other signs on the lung and the heart examination, you can say, okay, maybe that's hypervolemia. Okay? So that's important. You can have a normal looking IVC and that doesn't mean the patient is overloaded. Okay? So that's very important. And the diameter does not correlate with volume responsiveness. Okay? This is just a volume state indicator and reflects right atrial pressure. Now, if you wanted to measure, this is what would happen if you were to place an M mode on it. Typically, this M mode is placed at least 1 centimeter caudal to the hepatic vein insertion on the IVC, so that we don't measure the intrathoracic part of the terminal IVC, just to make sure we are intra-abdominal. So when you do that, you get this M mode trace, and you can see here, that's the IVC over time. This is the 2 examples here, and you can see that's IVC over time. And you can see that this IVC is varying significantly with respiration. See, it's nearly, the walls are nearly touching each other during some part of the respiratory cycle. And here you don't see that much of a variation. So you can actually take the diameters at the maximum and the minimum diameters, and then you can actually calculate various indices based on this. Now, is it really necessary to calculate? I don't think so. In real day-to-day life, I really don't do it. When I'm doing it and I look at it and it's obviously collapsing, I say, okay, he's hypervolemic. If it's not, I say, okay, let me look at everything else and make a decision. So that's very straightforward. But then if you're looking at any of the literature surrounding IVC, you will be usually faced with these various names. So it's good to know what they mean. The first one is IVC collapsibility. This is maximum minus minimum divided by the maximum. Okay. So this one, if it is more than 50%, it basically correlates with a low right atrial pressure and suggests that the patient is probably hypovolemic. Okay. If it is less than 50%, significance is not very clear. And you can use this in spontaneously breathing patients or in ventilated patients. It doesn't matter. All these patients. Okay. It doesn't really predict volume responsiveness. Like, is it going to tell you if this patient will benefit with fluid? Probably not. But if the patient is having a high collapsibility index and is hypovolemic, most likely is going to be volume responsive. Okay. It's not a direct correlate. On the other hand, in patients who have who are on the ventilator, not taking any spontaneous breaths, there are 2 more indices basically that are described. The more famous of this is the distensibility index. The denominator changes. Instead of minimum, it becomes instead of maximum, the denominator is minimum. Okay, and the cutoff is 18%. This, on the other hand, this does not tell us about volume state. It really tells us about what would be the response to fluid. So it's a volume responsiveness indicator. But really, it's got so many criteria that need to be fulfilled before you can use it, that in day-to-day bedside use, it's very rare patient whom you can use it on. The more important thing is, what does the collapsed IVC mean? Again, it means that the RA pressure is low. This patient is probably hypovolemic. What does the full IVC mean? Can't say. All I can say is he's probably not hypovolemic. Okay, and I'd need more information to decide. Okay. Of course, there are some situations where we can't really rely on the IVC measurement. In a right heart failure, for example, you have a patient with pulmonary hypertension and a right heart failure. You're going to have a fat IVC. even if the left heart is running dry. Okay, so for example, if you saw a fat IVC in that patient and try to pull out fluid, then it would result in a lot of hypotension. So that's one situation where we can't really trust the IVC to tell us what the volume status is. Tamponade is the other situation where again you'd get a distended IVC, but such a patient usually would respond to giving of fluid rather than pulling out of fluid. A raised intra-abdominal pressure would decrease the IVC size, so it would have the opposite effect. So some of those patients the raised IAP may have been because of very aggressive fluid resuscitation, say in a pancreatitis patient, for example. And so if you see a flat IVC and give more fluid, it's only going to worsen the problem. Another drawback is this all depends, even a spontaneous breathing patient depends on the type of inspiratory effort. Okay, so if a patient is a little acidotic and he's taking a very sharp and deep inspiration, creating very large negative pleural pressures, then even if this patient is well filled, it's going to cause, because of the large swings in pleural pressure, it's going to cause the IVC to collapse and make you think that this patient is actually hypovolemic. Okay? So if the respiratory effort is very abnormal, then maybe you'll have to think of the way that it's influencing it. Of course, sometimes it may be difficult. This is usually very easy to visualize, but of course, in some situations like cirrhosis, where there's a lot of attenuation of the ultrasound beam, you can actually decrease the frequency of the ultrasound beam to try and get penetration. Suppose there's a post-op patient and you can't really look in the midline, you can look at the IVC through the anterior or the mid-axillary lines through the liver. So that's another view that is described. Very severe gaseous distension, diaphragm really pushed up, can't see the IVC, but not really many solutions to that. Okay, so then we need to also, like I said, you can't just go by just the IVC, I need to look at the heart as well. So the goals here are to kind of find out what's the volume state by looking at the heart, and also to see what are the cardiac pathology that this patient have that might be interacting with my volume status assessment and might influence my decision on how to dialyze. So just a quick run through of the 4 views that we typically use in point of care ultrasound to look at the heart. One is a subcostal 4-chamber view. You're already looking at the IVC. It's the same location. The probe is just turned in a different way. The marker dot now faces left, and you're directing the ultrasound probe kind of the direction of the probe is toward the left shoulder. So the beam is actually going from below through the diaphragm, through the left lobe of the liver, and then looking at the heart. Okay, so this is the kind of view you'll get. You'll be able to see the liver up there, and then you'll see a 4-chambered view with the chambers that are closer to the probe being the right atrium and the right ventricle, and the deeper chambers being the left atrium and the left ventricle. So in this view, for example, that's the liver. That's the right atrium, right ventricle, left atrium, and a left ventricle. And of course, in this situation, you see this patient has a pericardial effusion as well. But this is a typical subcostal 4-chamber view. In a parasternal long axis view would be the next. We place the probe in the parasternal area, face the dot mark in the 2nd to 5th intercostal space, dot marker towards the right shoulder, and you'd basically see almost entirely the left heart. Okay, so this is what you'd see, and the structures that you see, basically that's a left atrium, mitral valve, left ventricle, LVOT, aortic valve, and the root of aorta, and a little bit of the RVOT over there. Now this is very useful to look at RV function, this particular view. You look at RV function to look at the valves as well. It gives us some idea of the volume state, and of course you can look at the pericardial effusion. You turn it 90 degrees clockwise from there, and you get the short axis view, the dot marker facing the left shoulder, and this is the kind of view that you would get. The LV appears circular, and you can cut it, you can slice the LV at different sections. Typically, we look at the mid-papillary view to make our assessments in most point of care ultrasound, and so you can see this is the mid-papillary view. We use this to look at contractility and also the relative sizes of the RV and the LV. So you can see this is actually not completely normal. You can see that RV is actually a little bit on the bigger side. It's pushing the interventricular septum down into the LV. But basically, this is a view used for both contractility as well as RV-LV comparisons. That view is also useful to look at what the volume of the chambers is, and I'll show you an example. This is a view called the apical 4-chamber view. The probe is kept at the apex, and the dot marker is facing left, and we kind of direct the beam toward the base of the heart. And this is what you would see. The apex is right at the top near the probe. You've got the right atrium and the right ventricle, left atrium and left ventricle, that's the mitral and the tricuspid valve. Now this is very useful again to look at LV function, as well as to look at the relative sizes of the right heart versus left heart, to look at any, some kind of right heart enlargement. And of course pericardial effusion as well. It'll also give us an idea of the volume because you can see the chamber sizes on this view. This is also useful for doing a number of Doppler studies to look at diastolic function and left atrial pressure, which is again something that's useful while making a volume status assessment. I'll come to that in a bit. Okay, so assessing the volume in all these views can be just done by looking at them and saying, does this chamber look like it's normal or it's all very small? So that doesn't need any measurement, but you can do measurements as well. So this is a short axis view, and you can actually in diastole measure the area of it, and with less than 10 centimeters square say that, okay, there's probably a decreased volume. There's a bit of a hypovolemia. But of course, there's in a hypertrophy, in a left ventricular hypertrophy, remember that'd be concentric hypertrophy, and there'd be a decrease in volume without it actually reflecting hypovolemia. So it's not very perfect. You can see in severe hypovolemia, however, you can also get what is called the kissing papillary muscle sign. Now you can see this is what the normal looks like. The two papillary muscles are, separated even at the end of systole. But you can look at this one here. At the end of systole, the two papillary muscles are actually touching each other. And there's almost zero volume in the heart at the end of systole. That suggests a severe hypovolemia. Of course, typical hypovolemic patients are not so bradycardic. They're very tachycardic. This is not what you would see. You'd see it be very rapid, and the papillary muscles would be touching each other. So that would be an easy sign. More often, I think, in your subgroup of patients, you would tend to want to look for what the LV function looks for, trying to see if there's an LV systolic dysfunction. So one is to actually look at it qualitatively. Just look at the images and see if there is LV systolic dysfunction. How do you do it? Now, this one is normal, and this is a patient with LV systolic dysfunction. And so a few things that you can see. First of all, you can look at how much the endocardium is moving in toward the center of the chamber. You can see there's a good inward movement of the endocardium. And here, if you look at it, it seems to be just moving, but not moving in. There's hardly any inward movement. That's one. The second is to actually look for thickening. If you look at the myocardium here, can you see that it's actually thickening with each contraction? If you look at the myocardium here, there seems to be no thickening at all. And the third thing is to look at the anterior mitral leaflet. You can see with the diastolic excursion, the outward excursion, the anterior mitral leaflet, it's going and nearly touching or even touching the septum. Okay? So there's hardly any separation between the mitral leaflet and the septum when it swings outward in early diastole. But if you look at this anterior mitral leaflet, it hardly moves out. Okay? So these three things will tell you that there is an LV dysfunction. So this is LV dysfunction on the parasternal long axis view, and this is what LV dysfunction would look like on a apical four-chamber view. You can also see that the LV has kind of become more rounded. That suggests that this is a chronic kind of dilated cardiomyopathy. Very poor movement. This should have moved all the way till here, perhaps. Anterior mitral leaflet, that's not happening. There's no thickening. There's a very little inward movement. So these three things can help you to kind of detect LV dysfunction, qualitatively. Sometimes, of course, this decreased movement may be only regional, and this is what it would look like. This is a short axis view. Of course, there is severe LV dysfunction. You can see the entire LV is not really moving in, but you can see that some parts are contracting better than the others. You can see that the anterior and lateral walls seem to be moving in, but whereas these walls are not moving in at all. So this is regional wall motion abnormality. So when you're looking for LV systolic dysfunction, you sometimes may find this, and the increased incidence of coronary artery disease in your patient subgroup means that very likely you'll see this sometime or the other. Now, if you want to actually measure LV systolic function, the easiest way to do it is do the M mode EF. You can't do this if there are regional wall motion abnormalities, but this is the simplest thing to learn and to do. It has a lot of problems, but it's probably the most reproducible. Is it the most accurate to real life truth? Probably not, but most reproducible among people. So compared to more complex ways of assessing EF. But in reality, in these kinds of situations, it's really not necessary to quantify and say this is the EF, knowing that most of these ways of measuring EF are prone to a lot of error. It's more important to say there is LV systolic dysfunction. And so if I see a fat IVC and there is LV systolic dysfunction, there is no hypovolemia, I am more likely to say that this is an increased intravascular volume. So it's more useful for that, and if you want to measure it, you can. There are more complex ways of measuring ejection fraction using Simpson's method, which is an area change method in the apical four-chamber view. They're not worth it in the bedside at all because our machines will never give you enough definition to get anywhere near the truth. So this is pointless and takes a lot of time as well. A few things to remember about LV systolic dysfunction when you're assessing is that if a patient is actually hypovolemic, what you see, the LV will appear to be doing much better than it really is. So sometimes after you fill up the patient's in shock perhaps, he's a little hypovolemic, you were doing in dialysis, developed hypotension and you did an ultrasound, he's a bit hypovolemic, and the heart seems to be contracting. Oh, it's not the heart. You must remember that when, and then there's a little bit of hypovolemia, or there's sepsis when there's a vasodilation, either the preload or the afterload is low, then the LV will appear to be doing much better than it really is. And so you should really reassess the LV after you filled up the patient or after you start the patient on vasopressors. That's one thing to just remember. The other thing, of course, I said EF is very, very prone to error. So don't go by these numbers. These numbers will vary. Even you just come back and do it on the same stable patient. After some time, you may get a completely different number. So, kind of take it with a big bag of salt. So the importance, as we said, we want to know this in a dialysis patient because, of course, it helps us make our decision of what the volume is like very, very surely. Plus, in a patient who has very severe LV systolic dysfunction, I'm also trying to see whether I'll be more prepared for some intradialytic hypotension as well. Okay. In addition to systolic, very important to also have some idea of what the diastolic function, the LA pressures are like. Why is this important? Because I'm sure you've seen many patients who come in with the flash pulmonary edema. You make an assessment, they actually don't have real hypervolemia. But often when you look at them, you assess them, they've got extensive crackles and pulmonary edema. And so we say, okay, he's just come in, I rush him to the dialysis lab, and I start ultrafiltering, and he came in with a blood pressure of 220, and in 15 minutes, he is on NORAD. I'm sure you've seen that happen again and again. So that is because these patients actually don't have an increased volume. This is just a kind of a redistribution because of an increased LA pressure due to a worsening diastolic function, probably because of an accelerated hypertension or a myocardial ischemia. These are two precipitants that we most commonly see. So it's useful to kind of know how to do this. Now, of course, this involves the knowledge of Doppler, which is, of course, we consider it a second level of point-of-care ultrasound, but it's not very hard and can be learned in 10 minutes. So we basically use an apical four-chamber view, and we use a pulsed wave Doppler to first look at the flow through the mitral valve. So that's the first thing here. And the flow through the mitral valve, which of course happens in diastole, is a biphasic flow as long as the patient's in sinus rhythm. So you have this initial flow, that's the E wave or the early wave. Second one, that's called the A wave. So we kind of look at this. There are various parameters. We can look at the ratio between E and A and the deceleration time and all. But if you want to take one single value, we just take the E wave measurement. Okay, that's very easy. Just put a caliper and place it. And then we place this pulse wave Doppler cursor over the, the mitral annulus. That's where the mitral valve leaflet attaches to the septum. And, of course, here we're not measuring blood flow. We are now measuring tissue velocity. So you need to switch to tissue Doppler. You can just do that on the machine. And then you would get a waveform of the annulus. Okay, obviously, the annulus is moving in the opposite direction to the blood flow. So in diastole, for example, the LA is getting smaller and all the blood is moving towards the LV. So when you take the blood velocity, it's a positive flow towards the probe, and the tissue is moving in the opposite direction, also in two waves, which we call E prime and A prime. Okay, so if all you need to do is measure this E prime. So we got two measurements. We got this E, which is a blood flow, transmitral early diastolic blood flow, and the E prime, which is the mitral valve annulus velocity. And that ratio should be less than 15. If it's more than 15, it indicates an elevated LA pressure, suggestive of maybe an LA pressure more than 18. As long as the patient's in sinus rhythm, of course. Atrial fibrillation, then all these things go out of the window. Then maybe you may have to do some other things. So, and of course, there are other ways you can assess diastolic function, even without calculations. If you look and see that the LA is dilated, or just the presence of LVH alone can tell you that possibly this patient already has diastolic dysfunction. So even qualitatively, you get some idea, but it's good to have an idea like this way. So if you have a patient who's having extensive B lines, but then you find that his IVC is plus minus, I'm not so sure. You look at his E by E prime and it's very low, it's only 6. Then you have to start wondering whether all these crackles and all of this is really a fluid overload or some other explanation in the lung perhaps. Okay, an acute lung injury, maybe an infective etiology, a viral pneumonitis, whatever it is. So you might want to start thinking of other things. So it is useful. This skill is useful. Little harder to learn than just plain 2D, but I think it's worth it for your subgroup of patients. And knowing that the incidence of diastolic dysfunction in patients who are needing dialysis is very high. So it's useful to know. The pitfalls are the same as any Doppler measurement. Doppler measurements, you have to do it very rigorously. Any slight change in angle would mean the whole thing is inaccurate. Though in this particular application, since it's a ratio, hopefully you made the same degree of error for both the E and the E. I mean, if the angle error, for example, will remain the same. But you must remember that Doppler, you have to be a little bit more rigorous in the way you do it. The RV, so as you're doing all these views, you might see some RV enlargement. This is a short axis view. We earlier saw the short axis view, the LV, we were expecting it to be circular sometimes, and the RV to be crescentric. Here, on the other hand, in RV enlargement, the RV is oval, and the LV is D-shaped. This happens particularly in diastole. The septum gets pushed in. Some people would even make measurements in 2 axes of this and show that they're not the same, something called eccentricity index if you come across it. Not necessary. If you see a flattening and not a circle, then you know that there is an increased right-sided pressure. So of course, why is that useful? Sometimes if in a patient who's very overloaded, in a patient who already has pulmonary hypertension, who also develops a fluid overload, this effect will become very pronounced. And so actually pulling out fluid might help by allowing the LV to actually become more round and contract in a more efficient way. The downside, or the other way to also look at it, is that many of these times you may find, like I said earlier, a fat IVC, a fat RV, but a flat LV. And so such a patient, if you try to pull out fluid, sometimes is very likely to go into hypotension. So this is a very tricky situation. And you must expect hypotension if you really think this patient is truly overloaded and needs any fluid removal. This is what it would look like in the apical 4-chamber view. So you can see this is the normal. So you can see this is normal. You can see that the RA is smaller than the LA. The RV is smaller than the LV. Typically, the RV is about less than 60% of the size of the LV. Okay? If it becomes equal to the size of the LV itself, that suggests that there's RV enlargement. Okay? So if you look at this situation here, the RV is way bigger than the, RA is bigger than the LA, and the RV is bigger than the LV. In addition, if you look at the interatrial septum, you can see that's actually getting pushed. See, normally it should get pushed to the right side. It's getting pushed to the left, suggesting a very high RA pressure. Same things are happening to the interventricular septum as well. It's getting pushed into the left side. Okay? So these are all not very difficult at all. If you put your probe there, and you'll be able to see this. It's not very subtle, and would suggest that, of course. So in this situation, a patient who's come in very breathless, your patient, which you think, oh, maybe it's just because he's fluid overloaded, maybe just an alternative pathology. Maybe it was a pulmonary embolism that's causing his symptoms, and you shouldn't really be trying to pull out any fluid. So sometimes, of course, you may actually see thrombus. This is actually a short axis view that shows a bit of the right atrium. This is a different view, so it's a right atrium. You can see the thrombus inside there. Some of your patients are also more prone to developing DVTs, and therefore it's good to be able to recognize this when it happens. Important thing when you're looking for any signs of RV enlargement and suggesting that, okay, that may be the cause of his breathlessness and this may be pulmonary embolism, there are 2 things. One is you can't use the ultrasound to rule out a pulmonary embolism. Okay, it is possible to have a pulmonary embolism with no RA-RV enlargement. Many smaller pulmonary embolisms will have no effect hemodynamically at all and will have no RV strain. And so it might look normal. So you can't rule out. But if you do see it in the appropriate situation, you can say, okay, this is possibly because of a pulmonary embolism. So that's one. Second, if you want to look at RV versus LV size comparison, your view, that means the apical 4-chamber view or the subcostal 4-chamber view, the way you get it has to be very thorough, because if you're not careful, even a normal person, I mean, if you give me the probe, I can show you how a normal person, I can show you the RV is enlarged, or an enlarged RV, I can make it look like the RV is small. So it's very important that, I mean, we don't have time to go into how that's exactly done, but when you're doing each image in point-of-care ultrasound, although we said, it's very easy, you can learn it very quickly, it is very important that the moment we acquire the image, the first thing is not interpretation. The first thing is to remember what are the quality markers of this image, and to make sure, try and achieve all those quality markers first by appropriately, manipulating your probe, and then interpret. That's very important. Otherwise, we'll be making so many mistakes in our assessment that we kind of lose faith in point of care ultrasound and stop using it afterwards. So important not to do that. Additionally, of course, I already showed you an example. Sometimes you might see pericardial effusions. So pericardial effusions appear as an anechoic area around the heart. And this is how they would look in different views. This is a subcostal 4-chamber view. You can see that that's the liver, and then you can see this fluid all around. Additionally, I think if you pay attention there, you can see that the right atrium, the free wall, is actually kind of collapsing in, and you can see that the free wall of the RV is also collapsing and touching the septum. So there's both RA and RV collapse in this particular situation. You can see this is a short axis view. You can see there's fluid anterior and posterior. Not a very great parasternal long axis view, but there's posterior and anterior pocket. This is a apical 4-chamber view. You can see that there are, there's a lateral pocket, apical pocket, and you can see there that there's a free wall of the RV is pushing in. So you can see there's RV collapse. So if you have pericardial effusion, so what's the, and of course sometimes you might see a lot of things. You might see swinging hearts, just another example of the RV collapse. So why is this? So few things that we must understand is that the volume of the fluid that you see, it does not tell us what its hemodynamic significance may be. Even a small amount of fluid may have a high pressure and may cause a tamponade. Okay, so volume is not equal to pressure. Second is, so therefore, really quantifying the volume is not really very important. You can just look at it qualitatively. What is it useful for? So if you have a large pericardial effusion, you must quickly look and see if there is any RA-RV collapse. If there is, then when you're trying to dialyze that patient, then the likelihood of intradialytic hypotension is higher. So that kind of gives you a heads up to what to expect in that patient. And of course, if a patient is in shock and you see this, you might want to know whether it is tamponade. So remember, for tamponade, we need a patient in shock with a full IVC and pericardial effusion with an RA-RV collapse, all of them. Sometimes you'll find patients who are not in shock. You're just doing it routinely and you find a pericardial effusion. So, oh, he's got a pericardial effusion. And when you look at the RA, it actually seems to be collapsing. This patient's not in shock. He's, he was just sitting up and talking to you, before his dialysis. So that is not tamponade. So remember that true tamponade happens because the pericardial pressure went up so high that it kind of overcame the RA pressure and started to push in. So the main problem there is a very high pericardial pressure. And that means that the only way you can solve that is, of course, one is to give the fluid to increase the RA pressure, but most importantly, take out the pericardial fluid. But in this kind of situation, when you don't have shock, IVC is not fat, it's varying like this, and yet he has an RA-RV collapse. That's a pseudo collapse. Pseudo tamponade. And that basically is also called a low pressure tamponade. Basically means that the pericardial fluid pressure has not increased. What has happened is the RA pressure has come down, possibly because you pulled out a lot of fluid or is already hypovolemic. So the solution there is to just give him more fluid. He or she doesn't need a tapping of the pericardial fluid. So remember that all have to be there. Shock, either with or without hypotension. Shock plus a full fat IVC, not varying IVC, and RA-RV collapse with pericardial effusion. Now all of this, of course, is helping us get an idea of how overloaded the patient is. And something that's come up more recently is that we can also look at the effect of a high venous pressure on some other visceral organs. Okay, you can look at it on the liver, the gut, and the kidney. And so this venous excess ultrasound. So what we do is the first step is to try and look at the IVC. You already know how to do that. And then when you look at the IVC, and if you find that the diameter of the IVC is more than 2 centimeters, again, like I said earlier, this diameter is taken at least 1 centimeter caudal to the hepatic vein insertion, okay, so that you're not measuring the intrathoracic part of it. And if it is more than 2 centimeters, only then would you go on with looking at whether this venous, because this tells you that, okay, the venous pressure is likely high, and only then you can start looking at the effects of it on the viscera. So you can measure it in the longitudinal view, as we did earlier. But then if you turn the probe 90 degrees, you would get a cross-sectional view of the IVC, and you can measure it there. Another effect of venous congestion is that normally the IVC is a kind of a flat oval, and as it becomes more congested, it becomes more circular, like you see here. And so even without measurement, you can look at it and say, that's a bit of a fat, plethoric IVC. It probably has venous congestion. So the first thing that we look at is the effect on the liver itself. You look at the hepatic vein. Now, we already saw the hepatic vein was coming onto the IVC, very easy to visualize. So you can look at it. Of course, can I see it from where I'm doing the IVC? Yes, you can, because there's one hepatic vein there. You can keep it in the mid-axillary line, like I've shown you here, the dot marker facing upward. You'll be just looking at interrogating another hepatic vein. So you'll see it as blood moving away from you, and then you can actually get a trace of it. And typically you would see 3 waveforms, and we'll come to those waveforms and what the abnormality would be. So we have a systolic, diastolic, and an atrial, so S, D, and A waveforms, and we'll just come to that in a bit. So this is the first step, looking at hepatic venous congestion. And then in the same location, with a slight tilt of the probe so that the beam goes a little anterior, you should be able to visualize, because you're looking from the right side, the right branch of the portal vein, or even the main portal vein, whichever is clearer to you. So you can actually just measure the flow in the portal vein. Now this would give us an idea of how congested the gut is. And basically you can look at it, it'll be flow toward the probe, so it'll be above the baseline, and you'll get this undulating waveform. We'll come into the interpretation of that. And the third is you look at the kidney. Standard visualization of the kidney. The right side is easier to visualize, you can look at either. And what you're trying to interrogate are the interlobular veins. So they are going to be running perpendicular to your probe. They're going to be running this way. And very often you'll see the arterial, when you put the color, sometimes you may not be able to see the venous. You'll be able to get the arterial. Doesn't matter, the artery and the vein are very close over there. So you can just place the Doppler there. And what you will get is traces of both the artery and the vein. So the one that you're getting above the baseline, this pulsatile flow, is the arterial trace. And the one that this continuous flow that you're seeing below, that is the venous waveform. So we really focus on the venous. And let's look at how do we interpret this. Now the normal in the hepatic venous flow is to have a large systolic, and then a small diastolic wave, and then a small reversal wave over here. That's in late diastole. That's during the atrial contraction. So that's normal. But as the venous congestion worsens, what will happen is the first thing that happens is the systolic wave actually becomes much smaller, and eventually the systolic wave reverses. So you'll get both the A and this S wave on that side, and only one wave below. Okay, so instead of getting 2 waves below, you'll get 1 big wave up and 1 big wave down. That suggests that there's a lot of venous congestion in the liver. Portal venous flow, normally like we saw it, you'll see a slightly undulating waveform above the baseline. If you were to measure the maximum and the minimum, you will get, the machine will tell you what the difference between the two is, expressed in an index called the pulsatility index. And so as the gut becomes more congested, you'll see that there is bigger variation between systole and diastole. And you'll get a more pulsatile kind of waveform with a bigger difference between the systoles and diastole. So that's what you see in the portal vein. In the renal vein, the flow below is almost continuous. But if there is renal congestion, then you'll start getting discontinuous waveforms. Initially you get one systole and one diastole, and eventually the systolic completely disappears. You'll be left with only one waveform. And the grading is based on how many abnormal waveforms you saw and how severe it is. Okay. So what are the difficulties? Again, visualization sometimes, especially in the kidney. Sometimes if your machine is not very great, the color flow may not be as good as the image I showed you, because color flow is very dependent on how good the computational power of the machine is. So sometimes that may be very difficult to place. And all these 3 measurements may be difficult when the patient is breathing, because it's kind of moving this way. And so it's coming in and out of your window. So you might want to ask the patient to take to hold his breath if that's possible. It's a very sick patient, that may not be possible. So those are difficulties with doing the exercise. The other thing to remember is this is just telling you what the effect of it on the systemic organs is. It's not essential to do a VEXAS to kind of decide if the patient is hypervolemic. Okay? So this is, for example, in a patient who's for example having heart failure and is having worsening renal function. If I saw a lot of renal venous congestion, then I might say, okay, let me just pull out fluid. Maybe his kidneys will get better with just the reduction in the venous pressure. So it's a very specific situation where it may be useful. Lung ultrasound, very, very crucial again, because that's often what we target, and a lot of a clinical examination to decide on whether we need to pull out fluid is based on our examination of the lung. The probe, we could use any kind of probe. We could use the cardiac probe, the abdomen probe, high frequency probe, microconvex probe. Any of these probes is okay. for most of these applications that we will look at today. The way to do it is the probe is held in such a way that the dot marker is facing headward. So the beam is actually cutting across multiple ribs, is perpendicular to the intercostal space. It's not placed transversely, it's longitudinally placed. And there's a little problem here because unlike all the other structures that we considered, the lung has a big surface area to cover. So if I would say, let me do an ultrasound of the lung, that's a large area to actually look at. And so there needs to be some kind of a systematic way to kind of examine the lung. And so people have described all sorts of different zoning, going from 2 zones on each side to a total of 28 zones. So much of variation. And this is a very simple one that we can just do in a patient who's, say, lying down and you're not able to reach the posterior. You can just look at, infraclavicular, mammary, axillary, infraaxillary. These are all areas that we are very familiar with from our auscultation days because they're the same areas. So you can just look at that. A little variation of this would be to add the supra, inter, and infrascapular areas. Now these are all just auscultation areas. So no fancy zoning. These are areas that we are already familiar with. So because there was so much of variation, there were some studies that compared all these different zoning methods in patients with dialysis who are requiring dialysis to make assessments. And they found that just doing 2 zones on each side is as good as doing 28 zones. So not really necessary to do too many. Okay. This is the 28 zone thing. So I guess if you're doing a study, you want to be very rigorous. That's the only time you'd probably do this, otherwise you wouldn't waste so much time on this. So what would you do? What would you see if you were to do the ultrasound in this? Now this is a low frequency probe. It would look slightly different with different probes, and I'll show you that as well. So you can see that you're going to see right at the top of the image of the structure that you're seeing are the chest wall layers. So that would be subcutaneous layers, the pectoral muscle, some intercostal layers. And you can see there's this dark area over here, and those are rib shadows. That means there's a rib here causing a shadow behind it, the rib here causing a shadow behind it. Now it's very important. Now there are all sorts of animal names for this image, but what is important is as soon as you place your probe to look at the lung ultrasound, the first thing is not, oh, what's the interpretation? Is just like I told you earlier, to make sure, am I getting the image right? And the one thing that you should look for is to see whether you're seeing the ribs and shadows. Sometimes if you don't see ribs and shadows, then probably what you're looking at is not the lung at all. If there is a subcutaneous emphysema, for example, you'll be looking at the air in between the chest wall layers, and you're not actually looking at the lung. It'll look just like lung. So it's very important to make sure that you can actually see rib shadows first. So you see that, then the line joining the 2 ribs, there's a bright white line that's called the pleural line. It's bright white because it's reflecting sound. I mean, what's actually reflecting sound is not the visceral pleura or the parietal pleura. Those are just thin membranes. They really don't reflect too much sound. But it's actually the air interface. So the ultrasound is actually passing through the chest wall layers, through the parietal pleura, through the visceral pleura, and then there's air in the alveoli. So this interface, if the ultrasound strongly reflects off any fluid air interface. So here's the tissue air interface. It completely bounces back off that and comes back, and that's why you get this bright white line appearance. And you can see that that line is also moving from side to side. That's called lung sliding. It's moving independently. It's not moving along with the layers above it. So that's a phenomenon called lung sliding. It just means that the visceral pleura is sliding on the parietal pleura. And that is because of course, it tells us 2 things. One, that air is actually going into that part of the lung, and the lung is expanding. And because the lung is expanding, the visceral pleura is sliding on the parietal pleura. Second, this visceral pleura is touching the parietal pleura. It's not separated by, say, a pneumothorax. Okay, so lung sliding is there, rules out a pneumothorax, and tells you that there is good air entry to this part of the lung. Okay. Now, if you look below the pleural line, you see all these horizontal lines, and I'm sure you're aware that these are called A lines. There are no actual structures in the lung like this. We just said that the ultrasound beam doesn't even get into the lung. It's going till the alveoli and is getting reflected back. So it really can't go inside the lung and bounce off to tell you what's inside. But these are reverberation artifacts. So what is really happening is that the ultrasound beam is actually coming in like this, reflecting strongly off this highly reflective surface and going back. But some part of the beam is actually reflecting off again at this skin probe interface, for example, coming back here, reflecting again and going. Now this is it's bounced twice or reverberated before going back to the probe. So it's going to take longer to go back to the probe. So the machine thinks, oh, it's taken longer, so it's probably come from farther down. and therefore draws a line that's further down. This line is drawn because some part of the beam has obviously reflected twice. Okay, so that's how these reverberation artifacts are created. Okay, see, these are called A lines. So that means anytime there is good amount of air inside the lung, I'm going to get A lines. Okay, and of course there'll be A lines even in pneumothorax. Okay, because there is air beyond the pleural line. There's going to be air. So it just means there's a strong reflection at the surface. And A lines are a part of normal lung, may also be a part of pneumothorax. Okay, but of course in a pneumothorax you won't get the lung sliding. So that's the only difference. Okay, so remember that always identify the true pleural line. Look for the rib shadows. Look for lung sliding. Look at the pattern below it. Okay, so for example, okay, not completely normal. Okay, so here if you see, that's a rib and shadow. That's a rib and shadow. Therefore, this is a true pleural line. Is our lung sliding? Yeah, it's sliding. What's the pattern of lines below it? Okay, there are a lot of horizontal lines, and then it looks like there are many vertical lines there. Now look carefully. These vertical lines are actually not real vertical lines. They're kind of gaps in the horizontal lines. These vertical lines are black or white? Are they white? There's one white one that comes along. I just wanted to show you. So can you see there's one white one that comes? We'll see more of those. Those are B lines, okay? But right here, you know, other than that, you can see that there are many things that look vertical. Those are really gaps in the A lines. These are called O lines. They are not true B lines, okay? So, there are other smaller, I don't know if you can see them here. There's some vertical lines that are white. They're starting from the pleural line, but they're not going all the way down. Those are called Z lines. I just wanted to kind of show you there are lots of other lines there. They mean nothing, okay? So all we want to look for is A lines and B lines, okay? So B lines are vertical lines. A lines are horizontal white lines. B lines are vertical white lines. They should start from the pleural line and go all the way to the edge of the screen. If they don't go to the edge of the screen, they're Z lines that mean nothing, okay? So how do we get B lines? Now, B lines, of course, come when there is some degree of edema of the interstitium. So there is either interlobular or interalveolar walls have become edematous. So normally, I told you earlier, the ultrasound beam comes through the parietal pleura, visual pleura, and then just faces air in the alveolus. Now that's not completely true. It's not just a big bag of air, right? They're all alveoli, and between the alveoli, there are these thin septae. But normally, the ultrasound doesn't even see that, doesn't even get into those septae because they're just too thin. Now, when those become edematous, those septae also become filled with fluid. And the ultrasound, of course, loves to get into fluid and pass through fluid. So it will just pass through fluid and it will go into these septae. But as it goes into the septae, it is then getting, on both sides are alveoli filled with air, and here the septa filled with fluid. It starts bouncing off inside the septa, and that reverberation kind of reflects back, and you get what the ultrasound machine draws as, you know, multiple small horizontal lines that look like vertical comet tails or rockets as they used to be called earlier. So these are B lines, okay? So differentiate them from O lines or Z lines as true B lines. Now a B line, or A lines of course we said is normal, but the B lines are always pathological unless they're very few and just at the basis. So less than 3 B lines right at the basis can be ignored. Anything more than that means, I mean, it is pathological, okay? Now if you look here, these B lines are fairly spaced out. You can see there's a good gap between them. You can actually see them discretely. So, you know, when initially when there's a bit of fluid overload, there's only fluid in the interstitium, this is what it would look like. As the quantum of extravascular lung water increases, what would happen is the number of B lines will keep increasing. The number and density of B lines correlates with the wetness of the lung. So wetter the lung, more the B lines. And eventually, all the B lines will be so many that they start coalescing together. And you can't kind of, you know, point them out as being discrete. And that's what we call the alveolar syndrome. It means that it's just getting much worse, okay? So few B lines at the basis can be ignored. Now, the number and density correlates with how wet the lung is. So that's very, very useful for us because one of the key things that we want to know is how wet are these lungs so that I can, you know, diurese this patient, ultrafilter this patient. So it's very important to know. And so there have been a number of various ways of counting the number of B lines, and all those kind of different scores that count the number of B lines have very good correlation with how wet the lung is. It also has a reasonably good temporal fidelity. That means if I were to fill this patient, he was not overloaded early, and then he becomes overloaded now, I can immediately take the ultrasound machine and it will show me an increased number of B lines. If I were to pull out fluid during dialysis, it will show me that the B lines are coming down. Okay, so there's good temporal fidelity as well, and so it is very useful to track the patient worsening or getting better with your therapy, and also, of course, very useful for making decisions. Now, I quoted an earlier study where I said, the performance of a clinical examination was not very good. It was only 9%, 3%. That was against B line scores. So it is possible then for a patient to have some lung congestion and a lot of B lines on the lung ultrasound, but not many clinical signs. And then you say, what's the point of that? Maybe this is oversensitive. Should I really be treating a high B line score? Does it really make sense? But so people have looked at that, and we now know that an increased B line score or increased wetness by lung ultrasound correlates very well with outcomes, mortality, as well as future clinically obvious fluid overload situations. And so it is important to treat it. And so therefore, this is something that is vastly superior to clinical examination, and therefore should kind of become part of your examination when you are wanting to find if a patient is congested. The B-line score, should you really do a B-line score? Now that's up to you. In the ICU, I really don't do a B-line score because I don't find it very useful. But if you want to document actual worsening or improvement, then you can do that. How do you do it? You can just count the number of B lines as you just place it in each zone. You could just do that. Or you could use a kind of a grading system. There are various things. There's a lot of heterogeneity in way people have done this. So, and really there's no difference as long as you stick to one system. Okay. So how can I use this? So like we said, we can use it to decide, if a patient really needs ultrafiltration, how much to pull out. And various studies have looked at ultrasound-guided ultrafiltration protocols. And what we know is that, of course, it leads to better lung decongestion based on symptoms as well as B-line scores, and better blood pressure control with lower intradialytic hypotension when you use an ultrasound-guided protocol. And we could choose patients who we could remove more fluid as well. And from echocardiographic perspective, decreased LV pressures and dimensions if you use an ultrasound-guided protocol than just plain clinical and weight-based protocols. Of course, this can also be used to predict intradialytic hypotension. So you may think, okay, he's got crackles, and you can think of, but if he's got no B lines, then you can say, okay, he's got a fat IVC, but he's not having B lines. Anteriorly, I'm seeing only A lines. Then you can be prepared that this patient may not tolerate a lot of ultrafiltration. So it can help you predict that. Persistent B lines or a high B line score also predicts higher mortality in the long term in patients coming in for dialysis. Okay, so this is just some examples of what situations that you might find. So, for example, if I were to just do a lung ultrasound, all these patients are breathless. They've come to you and you're rushing them to the dialysis lab. And if I were to just do an ultrasound of, say, the left lung, say, let's look at this. What do you see? Is there lung sliding? What's the predominant kind of pattern below it? A lines. There's only one B line, isn't it? There's an occasional one B line that's coming in. So, the patient is not very wet, right? On that, okay, that's on that side. On the right side, sorry, what's happening? Okay. So that was no lung sliding. So if there's no lung sliding, what would you think? No, sorry, this is the next one. But if there's no lung sliding, what if you didn't find lung sliding, patient's breathless, there's no lung sliding, what should you think of? Pneumothorax. What's the other possibility? I told you two things. Sorry? No, pleural effusion, you'll see fluid, so that's not going to confuse you. You're seeing a bright white pleural line like usual, but it's not moving. The other possibility is that there's no air entry to that lung, because only when air enters that lung and it expands will it slide. So if it's not entering, that means there may be some airway obstruction, a collapse, for example, also. Okay, so every patient with breathlessness may not be a fluid overload, but you can look at those things as well. So look at this situation. What do you see here? This side, predominantly A line, maybe an occasional B line. Look at it on this side. You're seeing many B lines. Okay, so here I'm seeing a lot of B lines on one side and almost normal on the other. What could be the possible etiology here? Could this be a fluid overload? No. So it's a focal or unilateral B lines. That's unlikely to be fluid overload. So this has got to be an inflammatory pathology. So some kind of a pneumonitis, early collapse, pneumonias, some alveolar hemorrhage, contusion, whatever it's, some focal pathology. This is not fluid overload. So you shouldn't be trying to pull out too much fluid in this situation. Okay? Whereas if you see something like this, lung is sliding on both sides. The predominant finding on both sides is B lines, right? There are tons of B lines on both sides. So first of all, here's a bilateral B line situation. So what are the possibilities if there are bilateral B lines? One is a fluid overload and pulmonary edema. The second is? Yeah, so it's not, yeah, correct. So it need not be only fluid. It could be an inflammatory process as well. It could be ARDS. If it's a very chronic process, it could be an interstitial lung disease as well, for example, okay? So very important. Here, of course, you can also see there is some pleural effusion. That again is something that you would see in a fluid overloaded patient. You could see it in an inflammatory situation as well. So in a situation like this, when you see bilateral B lines, it's very important, particularly in a patient who has come in, say, he was due for dialysis tomorrow, he's coming here today with a fluid overload, and you're wondering, is this really fluid overload, or was this something, an infection that kind of precipitated an increased pulmonary capillary permeability that led to him flooding his lung? That's something very common that we see. And then we start dialyzing, they become hypotensive, and then they come into the ICU. So it's important to kind of differentiate B lines due to fluid overload from B lines due to inflammation. Okay, so some ways to do it is, suppose if you have B lines due to fluid overload, where do you think they would start, or where would they be densest? In the most dependent area. I mean, if you're supine, it'll be all in the posterior, and as you come anterior, it'll get less. If you find a pattern other than that, then you have to start thinking, if there's a lot of B lines on the anterior and not so much in the base, then you say, hey, maybe this is not really a fluid overload. Second is, if you start seeing pleural line breaks, okay, you're seeing some of that here. If you can see this area here, you can see there's a broken pleural line, okay? And over here, if you see, this pleural line looks very thickened and granular, okay? And sometimes you'll be able to see a small area of consolidation called a subpleural consolidation. So all of these pleural line abnormalities also would suggest that it is an inflammatory process and not a fluid overload process. Sorry, 1 minute. I just point out one more. The other thing to look at, for example, you look at this. There's an area of dense B lines that you see. You know, there's one big bunch of dense B lines. Right next to it, there's an area of A lines. There's actually A lines sitting right there. A lines means a completely normal air-filled alveolus, sitting right next to a flooded alveolar unit, sitting right next to a flooded alveolar unit. Pulmonary edema is not going to spare one alveolar unit suddenly just for that. So usually you won't get these areas of sparing in a fluid overload, whereas inflammation is inherently heterogeneous. Even if on the X-ray it looks very homogeneous, actually it's very heterogeneous. So you would have different degrees of inflammation and you get these areas of sparing. So all of these are signs that would help you differentiate. No other way, you know, X-rays, clinical, you're never going to be able to differentiate. Ultrasound, you can fairly confidently say, hey, this looks inflammatory. I think we should be careful when we're dialyzing or pulling off fluid. The other thing, of course, is in addition to this, you're also going to be looking at the heart, and you can do the LA pressure. The LA pressure is low, and there's a lot of B lines, then it's more likely to be ARDS than a fluid overload. Okay, what do you see here? Lung sliding, A lines. What about here? That's a pleural line. Is there any lung sliding? No lung sliding. What's the pattern of lines below it? A lines. Okay, so this could be a pneumothorax. Okay, or of course it could be decreased air entry, but in that there are other signs that help to differentiate these two. We're not going to go into that. So that is possible as well, particularly because you may have just put the access and started dialysis, and the hypoxia, what that is developing, may not be the fluid overload, it may be the pneumothorax because of your procedure as well. Additionally, not directly related to the fluid management, but I think if you're doing vascular access in the IJV or the subclavian, it should become part of your protocol to post-procedurally scan and screen for a pneumothorax, okay? Way more sensitive than an X-ray or clinical findings. Of course, sometimes you might see pleural effusions, okay? So that's fairly easy to see. This is a CP angle view where the CP angle is filled with anechoic fluid, and you can see the lung that's floating inside it. Sometimes the fluid may be just only the dependent, the costovertebral recess. So this is the right side, that's the liver, and you can see right there, posteriorly, there may be a pocket of fluid as well. Normally, you're never able to see the spine in the thoracic spine. You're not able to see it because there's lung coming and blocking the view. But if there's fluid there, you'll be able to see it. Something called spine sign, not very fantastic. Of course, sometimes you might see a much larger consolidation as being the cause for the hypoxia. It may not be a fluid overload at all. So you can see this looks actually like liver. It looks like a solid structure. You can actually see this branching white pattern of lines inside it. That's actually air inside the bronchi. That's an air bronchogram. And actually, if you pay attention, you can see that the bubbles inside the air bronchogram are moving with each breath. This is called a dynamic air bronchogram. Not necessarily that you should get this dramatic branching effect. If you get a solid-looking lung with white dots inside it, that's consolidation. Okay, so that might suggest that it's a pneumonic etiology. Again, that'll. So all of these are kind of telling you, oh, okay, maybe the etiology is something other than fluid overload. So that'll help inform your decision of managing fluids during fluid removal during dialysis. Yeah, of course, the other thing to remember is that when you see a pleural effusion, sometimes it is difficult to know, is this pleural effusion, is this ascites, and you might need to, there are signs to differentiate, but we're not going. So you must be aware that pericardial effusion can be confused for pleural effusion, and ascites can be confused for a pleural effusion as well. So now let's put all this together. So for example, if I were to have a fat IVC with wet lungs, I think that's fairly straightforward, and I would say, okay, I think he is overloaded. I would try and pull out some fluid. A fat IVC with A lines, I say, okay, this is not ideal. I'd be very careful about pulling out fluid. And second, I'd be wondering, why is the IVC fat? Is there some other reason for the increased pressure here? Is it a right heart pathology? Maybe secondary to a lung pathology or intrinsic right heart pathology? Or is there a pericardial effusion with a tamponade? So I would do a cardiac ultrasound to look for that. If the IVC is fat, and there are B lines bilaterally, but there are a lot of inflammatory signs, then I'd be careful here. Again, so maybe, so of course, is there anything to prevent a patient with ARDS from also being fluid overloaded? No. It is possible that that is there, but you'd still have to be very cautious. If the pulmonary capillary permeability is high, it means that the intravascular volume may not be very elevated. In such a situation, then I would, if I thought that there is fluid overload, then in the ICU, what I would do is I would add on two things. I would increase the PEEP to try and increase the tissue hydrostatic pressure in the lung and move fluid back into the intravascular space. Second, I would use some albumin along with ultrafiltration to kind of help in this situation. IVC being normal, but with wet lungs, again here then I would be wondering whether this wetness is actually fluid overload. If it does look like fluid overload signs, then I would look at the left heart and see if there is something there, mitral valve, LV, diastolic dysfunction that's causing the flooding of the lung without an actual overall hypervolemia. And of course, if there's systemic venous congestion, then sometimes that might indicate that I need to pull out fluid to improve kidney function or gut function, but that would again have to depend on the finding that we see in all the other places. So just some of these scenarios I've just put together. So you can see here, look at this scenario. What would you do? This patient is, one of your dialysis patients has come in and he is breathless, and you look at his lungs, his IVC and his heart. What do you think? Want to dialyze him for fluid overload? Definitely not. He's very hypovolemic. Something else is wrong here. Maybe he's ketoacidotic and he's hypovolemic. I don't know. But whatever it is, this is not a situation where you want to pull out fluid. Look at this. IVC is looking fat. A lot of B lines there in the lung. And that's what the heart looks like. Okay, so this is again very easy. It might say that, hey, it may not always be typical. Most cases, these things kind of come together. Sometimes they may not match. And so in this situation, I would be very confident to pull out more. I would be maybe a bit more aggressive if he's already hemodynamically stable in pulling out fluid. Here, you can see the IVC is fat. What happened there? Okay, what does the lung look like? Looks very dry, right? Only A profile, only A lines. And I'm having this pericardial effusion with RA-RV collapse. So here again, I would be very careful. This patient would need fluid rather than pulling out fluid. I mean, such a patient you may actually look at this when somebody becomes hypotensive during dialysis, and you might find this. And you look at the IVC, is looking fat, and say, oh, it's not hypovolemia, but actually when you see the rest of it, you say, oh, I need to give him fluid, and then his hypotension will recover. Okay. Pneumothorax also. So sometimes hypotension to dialysis may be because of the vascular access that you just put in earlier. So that could be the cause. The IVC can look fat because it is a form of tamponade that's actually happening. So in tension pneumothorax, you get a fat IVC and you get signs of pneumothorax. And of course, the breathlessness may be because of a pulmonary embolism. You saw this RARV enlarged, fat IVC, dry lungs, and then you may or may not find a DVT. This is what a DVT looks like. That's the artery, that's the vein. We are actually applying pressure. That's a compression ultrasound of the vein, and you can see that the vein is actually not getting compressed. That's because there is a thrombus. That's an acute thrombus, so we're not able to see it as an echogenic mass, and that's DVT. And of course, sometimes you may find that the patient is neither here nor there, not very hypovolemic, not very overloaded, normal looking heart, and the breathlessness is not due to a fluid overload. So you get all combinations and you can reason it out. So remember to put all these things together: IVC, cardiac ultrasound, lung ultrasound, and whenever it's indicated, VEXAS as well, to make your decisions. Okay, any questions?
Thank you, sir, for your fascinating and practical talk, which has equipped us with a clear and actionable framework to approach patients. There are a few audience questions which I'd like to ask. How often in your practice do you see on a lung ultrasound signs of a lung infection in a patient with CKD admitted to ICU with an acute pulmonary edema?
Too often. So almost every patient we've started looking at any time the patient does come in with, okay, he's got pulmonary edema, I'm just shifting him into the ICU because he needs NIV or he needs intubation, and so that we can dialyze him. We now have started routinely asking the question, can we rule out an infection, because we see it so often. And because the ultrasound makes it so easy to differentiate, in a few minutes we know for sure if there are any signs of inflammation, we can say, okay, he's got an inflammatory process. It could be both. He probably has both often, but we can make that out now. So with great confidence, we can differentiate that. So that's very useful.
So one more question. In dialysis patients, is there a role for evaluation of heart after ultrafiltration? Can we compare the heart or IVC images at various time points?
Okay, so people have looked at this by looking at the lung, looking at the B-line score, looking at the heart and the IVC. Okay, so we know that the heart, the chamber dimensions and IVC actually improves when you're ultrafiltered, and you use a lung ultrasound directed ultrafiltration. You're able to get much better reduction of the IVC plethora and the over-distended chambers. How does that correlate clinically? Does it make a difference to mortality outcome? Whether you're not seeing any difference like that. So should you do it routinely? It may not be necessary. In the patient who you think that you filtered and you think, does he need some more ultrafiltration, you could look and see. If he still looks plethoric IVC, lungs are still looking wet, you can go ahead and filter some more after his whatever you thought of clinically. So you could do that. There is no particular benefit we have found. So thank you.
Thank you very much, sir.
Sorry, this is just this nephropocus.com is just a useful website by some nephrology residents in the US. Very nice website with a lot of small tidbits of information that I found very useful. So.
Thank you very much, sir, for this exhaustive presentation, and we really enjoyed it thoroughly. I request you to kindly accept a small token of appreciation from our organizing committee.